Our first case will be a case by the name JK. This is a 61-year-old from the male surgical ward. The patient is from Aldai. He was admitted on 9th, and I was able to see him on 13th of June. So they are not responding. So he came in with a chief complaint of a tongue lesion, which has been there for 10 months, and facial swelling, which has been there for 1 week. So the facial swelling started a week ago after the patient was being done biopsy of the tongue lesion, and it was on the left side, painful. Affecting vision of the left eye due to the swelling, associated with difficulty in breathing, reports also hotness of body and snoring a lot at night, but no night sweats. So the tongue lesion has been there for 10 months, slowly increasing in size, painful, associated with difficulty in feeding, and also associated with the excessive saliva and the mucus secretion. However, he denies any history of trauma. The patient reports history of weight loss due to inability to feed and fevers, however mild, but no night sweats. So on a past medical and surgical history, those little significant. This indicates admission at this facility. Family social is married with 6 children, NHIF contributor. This is a small-scale farmer. No history of smoking. However, the sons reports that I think the patient has more than 20 years before smoking or taking alcohol, and there is no history of malignancy in the family. So review of system, it was unremarkable. So in summary, I'm presenting a 61-year-old male from Aldai, presenting with the complaints of the tongue lesion for 10 months and facial swelling for 1 week. So on general exam, the patient is Ikoguan in fair general condition, not penile jaundiced. However, he had a cervical submandibular and supraclavicular lymphadenopathy. The vitals are normal. So this is the patient tongue lesion. It was difficult to examine because he could not open the mouth full due to pain. So it was exophytic, erythematous from what I can see, but that's what I can see. I didn't go further other than that. So this investigation is done at our facility. UEZs are normal, urea of 1.58 with creatinine of 51. CBC, he had a weight count of 5.74 with HB of 13.8 and platelets of 410. So this is the histology of the report of the specimen of the tongue lesion. So the conclusion was features seen, these are consistent with well-differentiated squamous cell carcinoma. So this is the head and neck CT scan done at our facility. The sinuses were clear. However, from the report, there was a retromalar lesion. Okay, the sinuses, I can see they are clear. So the brain, there's no any lesion noted, but most it was on this area. So there's a mass, from what I can see, there's a mass on this side, but it's not well differentiated. So from the report, radiological report that we got, there's another picture of the head and neck CT scan. So the report says there's a heterogeneous tongue mass, approximately 4.7 by 4.1 centimeters, and the mass is continuous to the left retromolar space, left pharyngeal space, and also it's filling the left fossa of Rosenmuller. So there's left diffuse posterior neck ill-defined masses with loss of normal facial planes extending from the left retromandibular region up to level 7. So both left and right submandibular glands, they had heterogeneous enhancing lesion, querying maybe the glands have been infiltrated by the mass. So there are also bilateral level 1 to 5 lymph nodes, and then some of these lymph nodes, they had central necrosis. So they had an impression of a diffuse tongue, postnasal space, left buccal muscle, and left posterior neck space mass. And then I think they could be the epicenter of the tumor. So, and they also level 1 to 5 bilateral cervical adenopathy. So the point of discussion today, we wanted to know what's the best management approach to this patient, considering that these lesions, these tumors, they tend to respond poorly to chemotherapy. So what's the input? Could we approach surgical and also radiotherapy? So thank you.
Okay, thank you, Dr. Kisulu, for that presentation. Clearly, this is a very advanced disease in terms of tongue CA. It's a patient who has trismus, unable to open his mouth. There are two possibilities. Most likely, it's because of the tumor infiltration into the internal pterygoid muscles, which are helping in opening the mouth. And most likely, that's the possibility. And then you're talking about a 4 by about 5 centimeter tongue mass. Is that patient able to stick out his tongue?
No.
So we are talking about deep tongue muscle involvement.
Yes.
And then you talk about it goes to the left retromolar trigone.
Yes.
And then it also goes up into the Rosenmüller's fossa.
Yes.
That is near around the nasopharyngeal space.
Yes.
And then you talk about the parapharyngeal space. So my take is that if you are to do surgery, you need actually to get R0 or at worst R1 resection. In this case, probably the surgeon will get away with R2 resection. That is leaving up behind gross tumor. Because I don't know how, maybe the maxillofacial surgeons can correct me, but I've never seen them like cutting up to the Rosenmüller's fossa. And yeah, sometimes when it is in the retromolar trigone, they can do the commando procedure. Yeah, but maybe they can tell us more. But to me, it doesn't look like it's feasible to get an R0 or R1 resection. So it's quite an advanced disease. I will actually recommend neoadjuvant chemotherapy followed by radio. Clinically, from what you've described and from the images, it's a T4BN2. The other thing which you need to look at, did we do a chest X-ray and live ultrasound?
So we had requested, but as of last week on Thursday, we have not gotten back. So I think I'll go there today and check whether the results are back.
Yes, because this is very important. We need actually to know, are we treating as a metastatic disease or are we treating as a like a radical, locally advanced head and neck cancer? Tongue. So we need to get that even before calling in the surgeons. And the other thing about especially oral cavity, you know, in head and neck, we have the oral cavity or pharyngeal, hypopharyngeal, and then laryngeal. And then, of course, you have the thyroid cancer. So for oral cavity, usually if it is a T1 or T2, surgery is a preferred treatment. T1, T2, those are lesions less than 4 centimeters. And if you look here, this is already something which is about 5 centimeters in size. It's at least a T3. And when about the deep intrinsic muscle involvement, that's at least a T4. Yeah, T4A. So just looking at that, probably surgical intervention may not be possible. And then also they need to, you know, like surgeons need to do neck dissection. So when you have very big nodes, a very big tumor extending into the parapharyngeal space and up into the Rosenmüller's fossa in the nasopharyngeal area, it may not really be, it will be very morbid surgery. I mean, you may have to take out half of the patient's face for you to get a clean margin, or at least R0, R1 resection. And the other thing is that also they respond decently to chemo radiation, but in this case, I will not recommend upfront chemo radiation. I will say neoadjuvant chemotherapy first, and then we review after about 3 cycles for possible chemo radiation. but it's important to stage the patient.
Oh, just to seek a
Thank you.
clarification.
Please go ahead.
Did you say that you need to give a neoadjuvant chemo like for 2 cycles before we reevaluate?
Yes, usually we give 3 or 4 cycles of neoadjuvant chemotherapy. And then because the main treatment here with radiation for locally advanced head and neck cancer is chemoradiation. But then because the tumor is so big, we will give at least 3 or 4 cycles of neoadjuvant chemo and see if it's responding. Then we can actually sometimes we give up to 6. But then if you look at the toxicity, because we want to give the chemo at the same time with the radiation. So we'd rather give 3 or 4 treatments of chemoradiation, maximum 4, and then they continue, of neoadjuvant chemotherapy. Then thereafter they continue with chemoradiation. So concurrent radio and chemo.
Okay, thank you, Dr. Let's hear other input.
I have a question. You got a CT scan of the head and the neck. Why was not the metastatic CT scan ordered at the same time? Because that would have been more informational than waiting for a chest x-ray and an ultrasound of the abdomen.
That's a good question, but the person who ordered, I don't think had this idea of metastatic workup in mind. So I think most of them, when they learned the words, they first requested this. So with that in mind, I think creating more awareness and we'll be aware a lot more next time. So we'll order that.
Go ahead, Dr. Obakas.
Oh yeah, you said the patient had NHIF.
Yes.
And is an inpatient.
Yes, doc.
Yeah. So I think we also need to discuss with the radiology department. We need protocols for head and neck scanning. Like we need to have protocols for lung cancer workup. For instance, in lung cancer, you must at least scan the adrenal glands and the liver when you're doing the CT check. And for head and neck, you need to scan at least the chest. When you're doing the CT check, at least include the liver in protocol, so that you can easily get that. But in Vietnam, actually, for the minimum of just festival. But you can get a CT much.
Doctor, we can't hear clearly. Maybe you can just repeat the last statement, please.
I think not just for lung and for buccal or head and neck cancers, any cancers that you see, you suspect, you have to do a metastatic workup, which involves CT scans, which would be best, sometimes MRI. And I think a lot of delay from what I saw on the wards is that you do, the thing in question and then you wait, and the queue to get a CT scan is very long. So I think from an oncology perspective, anytime you suspect cancer, you have to do the full metastatic scanning. And if they have NHIF, it shouldn't even be a question. It's for the patients that don't, that you're trying to really budget the metastatic workup. But for him, it should not have been a question to order the other CTs at the same time.
Okay, I think from a surgical perspective, when I look at this patient, when I look at the patient, the size of the tumor, it's quite a large tumor, and I think it's involving almost the entire tongue. Making the section of this tumor almost it makes it very difficult. But also, when you look at the extent of it into the retromolar space and the fossa of Rosen molar, you can't excise this tumor margins for sure. And also, if you have to do the total excision of the tongue, you'll have to do a total glossectomy and make it. I think surgically, I would not go for. And also, the level 1 to 5 nodes, it will require almost a radical neck dissection bilaterally. So I would support what the oncologist had said. We would prefer we go with the chemoradiation option. I don't think it's a resectable tumor. Chemoradiation would give us the best option.
Okay, thank you for that input. Any other input?
How is his ability to eat? Because the question is now you're going to send him to chemoradiation. Does he need a feeding tube? And that is not easy as well, because to intubate him, it has a lot of risks. He can't even stick his tongue out, which means he probably can't protect his airway really well. So if he's able to drink or eat purees through the mass, that would be the best until the tumor shrinks. But that's a question, I think, from a general surgical perspective that needs to be answered.
So the patient can only drink or eat soup, but not solid food.
What about puree? Because if you can get purees in, then that's fine. And what is his nutritional status? Because he's been living with this mass now for 10 months.
So the patient is not so wasted, but feeding is a problem. So I think maybe you can do maybe an NG or something. No.
The other thing about the patient, when you're describing the history, you talked about the facial swelling, which just started a week ago after the biopsy was done. Was there infection after the biopsy that could be presenting as an infection for the difficulty in breathing, hotness of body? That could be a sign of infection. And I looked at that picture. I don't know whether the photo was taken with the tongue elevated, but the tongue looks elevated, which could also be a sign of like a Ludwig's developing on this patient as well, on top of the tumor. Is the patient in antibiotics? Or
Yes, the patient is on antibiotic, and the reason for admission, we're thinking of infection. And actually, when first seen by the dental department, they thought of Ludwig's angina. But when they did the CT scans, they ruled out Ludwig's angina, but the patient is on antibiotics.
But I think the patient should be have an NG tube for feeding purposes, even as you plan for the chemoradiation.
I agree.
Yes, I mean, just to add on it, it's very important to make sure the patient has adequate nutrition. In terms of most of these patients don't complete treatment because of nutrition, because they get a lot of mucositis and all these oral infections in the mouth during the radiotherapy. Sometimes we end up putting a plastic feeding tube. Sometimes we do it upfront if it's very advanced localized tumor. So if the patient can have an nasogas NG tube, then he can actually continue with that. And then when he starts treatment, we'll continue with it until he completes treatment. Because nutrition is very, very important. I don't know if we have a nutritionist there, but they need at least, in my knowledge, I think about 2,000 kilocalories per day. So we need to look at that very, very seriously also. But we recommend adjuvant chemo. It's very big. Such a team is so big. You can look at the patient. I think also the left cranial nerve 7 is involved. If I look at that, that means probably it's infiltrating into some of those salivary glands or parotid glands, or compressing against the 7th cranial nerve on the left. That's quite big, and there's Christmas. So we can do some neoadjuvant chemo. I will suggest maybe carboplatin and paclitaxel, platinum-based chemotherapy. And after 3-4 cycles, they do the combined chemo and radio at the same time. Thank you.
Okay, thank you, Dr. for your input. Are there any other recommendations or suggestions? I think Dr. Akuloba has joined us, so maybe he can say something.
Hello? You can hear me? Okay. Okay, first I would like to say that thank you very much. I was invited by our head of department, Dr. Siele, but the people coordinating the tumor board meeting carefully left me out, which is a good thing. That means even my comments are not required. But I'm afraid I think I've seen this patient, and we had recommended oncology review. And I think it was after I recommended that is when you came to see the patient. And the tumor board meeting, therefore, maybe is an invitation through the file, which I have not seen. Thank you very much for that, that invitation. Most of our patients with squamous cell carcinoma usually present late. It's not unique in Kenya or in this part of the world. I still remember one of my professors, Professor Makoha, told us that prostate cancers, we live with them until when they are late, when they go to see him. Him is a urologist. So the same thing with the squamous cell carcinomas that we see around here. This is one of the patients who may have come even to see us early. And when we normally tell them, let's do biopsy to find out what disease it is, they usually avoid anything to do with the cut. That's usually the problem. If you want to just put a knife on that lesion, they will tell you, no, doctor, what you want to fikirie. Let's go and think about it. They go, and our competitors in the social medicine world, the traditional herbalists, take over. And they start feeding the patient on bottles of herbal medicine as the lesion grows large and large. Now, when the lesion now reaches this stage, when the patient is not able to feed, the tongue is elevated, they are, you can even see, as the previous speaker has said, we are having involvement of the cranial nerves, is when they come back to us. And usually they are in very desperate situation. For this particular patient, in terms of way forward, I don't know what people have said, but me, I think maybe neoadjuvant radiotherapy or chemoradiation. That's what I will say. Thank you very much.
Okay, thank you for your input. Just to bring you speed to what we have recommended. So we have decided that the patient to get neoadjuvant chemotherapy, 3 to 4 cycles of carboplatin and paclitaxel. Then we assess the response of the treatment. Then after that, we can send for both chemoradiation. So that's the way forward. But apart from that, we had not done a metastatic workup. So we are going to do that, and also to improve nutrition status of the patient by putting the NG tube. Yes. So I think with no further comments, we'll proceed to our case number 2. Thank you.
We have it, can we?
Yeah, we can pull it up. Oh, there it is. Oh, there another.
So I'm Adalbert Omwamba. I shall be presenting the next patient. So it is a patient by the initials PK, 15-year-old female from Kisii, who presented with a cough, difficulty in breathing, and chest pain, all for a duration of 2 months. So the patient presented on the 29th of last month with a 2 months history of dry cough that was associated with chest pain and later developed difficulty in breathing. She was sent for a chest CT scan which showed pleural effusion and multiple lung nodules. Primary was unknown at that point. So she had thoracocentesis thereafter. Gene expert and pregnancy tests were negative. So further review the following day revealed that she had a vulva mass that she was concealing from telling the clinician. So the vulva mass had been long-standing, had been biopsied in November of last year and showed that there was a round blue cell tumor, and immunochemistry was recommended at that point, but it was not done until later, early this month. So from immunochemistry, we found that it was diffusely positive for CD99 and negative for desmin, EMA, S100, synaptophysin, chromogranin, and MPO. So these findings were consistent for a primitive neuroectodermal tumor, but correlation with the clinical and radiological findings were found to be essential. So she has no previous history of admission to either a medical or surgical ward. She's a Form 2 student. On examination, she was in a general condition, but she was in mild distress. She was not pale, not jaundiced, not cyanosed. Those were her vital signs. Local examination, there was a mass at a right labia majora measuring 6 centimeter by 4 centimeter. It was firm, mobile, and non-tender, and there was no inguinal lymphadenopathy. Systemic examination, respiratory exam, there were bronchial breath sounds bilaterally. Abdominal exam, there was normal abdominal fullness, no organomegaly, no masses, and there were no area of tenderness. Other systems were essentially normal. So this is a chest CT scan. So from the finding, we find there were widespread nodular masses of varying sizes in both lungs. The largest measured up to 7 centimeter in diameter. There was centrally hypodense areas were noted within the nodules. There was infiltration of pleura on both sides. There was minimal right-sided malignant pleural effusion. Heart appeared normal, bones were normal. So the conclusion were widespread bilateral lung nodules with associated region with associated right-sided pleural effusion. So at that point, the radiologist made a conclusion of chest metastasis squaring primary. So this is the histology report that was done in November last year. And it showed, so what was taken, showed on microscopy, 2 huge tissue biopsies together weighing 200 grams. They have a rough surface. The largest measures 10 by 9 by 4 centimeter. Other measures 8 by 9 by 6 centimeter. The other areas 8 by 2.5 centimeter. Cut section, variegated hemorrhagic with the necrotic areas noted. 6 cassettes taken. Microscopic appearances, microscopic examination. Sections show tumor comprising an extensive infiltrate of round blue cells. These show a monotonous population of round blue cells with a scanty cytoplasm. Scattered abnormal mitotic figures are seen. 4 out of 10 high power fields in areas. The tumor cells are thrown into nodules with thickened hyalinized fibrotic intervening stroma. The vascularity is prominent. Tumor extends to the margins of excision. Intratumor hemorrhages is noted. However, necrosis is not a feature. So, conclusion, right labia majora mass biopsy. The morphological features confirm the presence of an extensive infiltrated round blue cell tumor. Immunochemistry is mandatory for further characterization and categorization for a definitive diagnosis. Diagnostic consideration include embryonal rhabdomyosarcoma and malignant skin adnexal tumor. So immunohistochemistry ordered later. So in the presence of appropriate and adequate control, the tumor cells show the following immunophenotype. So CD99 was diffusely positive and the rest were negative. So in conclusion, a perineal mass, a small blue cell tumor with a histochemical and immunohistochemical features compatible with a PNET. Correlation with clinical and radiological findings is essential. So these are the other tests that were ordered. FP was within normal ranges, beta HCG within normal ranges, and LDH was elevated. So point for discussing this patient, one, is the clinical picture consistent with a primitive neuroectodermal tumor? Two, is there a need for further investigation? And three, what is the best management for this patient? Thank you.
Maybe can you get a comment from pathology? I mean, do you have maybe a pathological comment?
My name is Kibeta. I'm wondering what particular comment are you interested in, Dr. Pakas?
Yes, Dr. Does it actually looks like a small round blue cell tumor, and it is a metastatic PNET. I was just thinking maybe you are interested in more immunos.
Yes.
But it doesn't look. Oh, yes, that's what I wanted to hear.
Yes, so I've gone through like when the presentation was being done through the two reports, and the case is 15-year-old lady with like valval genital huge swelling as well. That initially morphologically looked like a small round cell tumor with differentials being the other like more common disorders there, like the Botrytis embryonal rhabdomyosac. But then from the immunohistochemistry, quite a number of the antibodies done were negative, and the one that is shown to be positive was CD99. That is favoring like a peanut Ewings. It's Ewings peanut is it's not a common feature, especially in the genital tract, but it can occur as well. It could occur, and given this test, I think like the antibodies that were done in terms of immunohistochemistry, like desmin is ruled out rhabdomyosarcoma. EMA has ruled out any epithelial lesion or a tumor, because it's an epithelial marker, meaning any other small cell tumor that has an epithelial origin has been ruled out. And then S100 as well, neural tumors, and they akin to neuroblastomas have been ruled out as well. Synaptophysin is also, it's a neuroendocrine marker, meaning the lesion is not like a small cell carcinoma of neuroendocrine origin. And then chromogranin as well is neuroendocrine. Myeloperoxidase was to exclude myeloid sarcoma, like a granulocytic sarcoma that can as well present as a small round cell tumor. So with all these, looks like with given the differentials of the many differentials of small round cell tumor, I think CD99 has really narrowed down to peanut ewing. I don't think it. The other antibody that I don't see there is a lymphoid marker like a CD45 LCA, but it morphologically it would have like have pointers, so I would not really doubt about it. So I think everything clinically and morphologically as well as immunohistochemistry seems to be consistent with the peanut ewing.
Thank you, Dr. Now, this is already metastatic disease, so we need to define our goals of treatment.
Dr. Opakas, we cannot hear you.
I think you lost him there. Maybe you need to call him sometime later. But as he was continuing, that is true. A valvular cancer which has already metastasized to the lungs, the goal of treatment changes. We no longer think about removing the primary tumor, but how long we can perform its life. Is he back?
Hello?
Yeah. Hello.
So sorry, I think I got cut off. So, I mean, we have metastatic disease here, and it's a peanut. You know, peanut tumors, you need an aggressive, basically cisplatin-based chemotherapy. There are many regimens which we can. Then the other thing which I would like to point out, in this case where a patient has lung metastasis, a valvular lesion, we can treat, our goal of treatment is number one, improve quality of life, and number two, expect the patient, if possible, if you can prolong the life, then that is important. But what is more important is the quality of life. So for the lung metastasis, chemotherapy should be the way forward. We have many regimens for peanut and these Ewing's sarcoma type. So generally, there are cisplatin-based chemotherapies, which are usually given, I think we go up to 12 cycles. I would actually recommend that maybe the patient can get some maybe 6 cycles of chemo. We review the chest radiograph and also clinical evaluation of the lesions. Is it improving or not? And then if the lesion is causing so much distress in terms of if it's too big, if it's bleeding, if it's causing a lot of pain, we should be able to give radiotherapy to that lesion. That's a palliative course, maybe 5 sessions of radio to relieve the pain and bleeding and any discomfort. Thereafter, the patient continues with palliative chemo. And on this case, I will actually recommend the palliative team to be on board and maybe lead in terms of palliative care. That's my take.
Okay, thank you, Dr. Hari. Dr. Ganda?
Saying that once you're already palliative, then your goals of care are clear. Anything that you do is just to improve quality of life and how many years they're going to live. But that needs to be told to them because they might not be willing to go through all that, taking the fact that they're coming from Kisii. But the things that you can do immediately is at least start the chemotherapy if they're going to accept that kind of age. I don't know what the prognosis is. I have no experience with those kind of tumors, but I think it is not very good in the next 5 years, because most likely it will recur again, even after the chemotherapy.
Yeah, I mean, it's a metastatic disease, and with lung metastasis, lungs are vital organs, so it's a very prognosis. And most of peanuts are actually difficult to treat. It's not like a lymphoma, but they actually respond well to chemo. But they definitely will come back. And at some point in time, we may have just to do.
Yeah, that's okay.
I agree. It's important we counsel the patient quite well and inform them about the prognosis. And also, that's why palliative care has to take a lead role in this. Thank you.
Okay, thank you all for your input. With no further delay, we'd like to go to the third case, and this will be presented by the Jaramogi Godiga team.
Are you able to see the?
Yes, we can see you.
Are you seeing the presentation?
Maybe. Hello?
Yes.
I'm saying maybe you can share from your side.
That's okay. That's what is good.
It's okay, we can see.
Can I see the slides now?
There's our window.
So I'll start presenting a case on a huge chest mass. Are you able to see the presentation?
Yes.
Okay, so this is a case on a huge chest mass and a chest and neck mass in a 22-week gravid woman. Next slide. So this lady presented with she's a 25-year-old woman, presented with neck swelling, breast and left upper limb swelling, breathlessness, and the above had been for 3 months. So she reports that the swelling started on the left breast and then went to the axilla and later involved the neck. She also has skin nodular swellings reportedly from childhood. So status is non-reactive and there's associated weight loss, but amount cannot be quantified. So past medical history, this is the index admission. Others have been for deliveries. Family social, the patient is not diabetic, not hypertensive. No positive family histories of any chronic illnesses, nor cancers. Food and drug allergy, no reported allergies to any food, no drug. On examination, there was a middle-aged lady in some respiratory distress, not pale, not cyanosed, not jaundiced. She was at ECOG 4. The vitals were at a pulse rate of 138, respiratory rate of 28, temperature of 36.8 with a BP of 130/80. Respiratory system, the trachea was shifted to the right and there was dullness to percussion on the left side of the chest. No air entry was, however, noted on auscultation on the left lung side. The anterior chest wall, there's a firm upper chest wall mass involving the neck and the axilla. No bruise over the mass. The left breast is enlarged, fluctuant, and some masses were palpated. The severe system, there was resting tachycardia, S1 and S2 were present, no murmurs. Per abdomen, it was soft, mild epigastric tenderness, however, no masses palpated. CNS was stable. So the management that the patient was put on, pain management, patient was propped up, was done for chest x-ray, a neck ultrasound, a breast ultrasound, and an obstetric ultrasound. Was to have an MRI chest done, but the patient could not tolerate lying flat, so the procedure was aborted. Core biopsies of the lesions were taken, and that we are waiting histopathology results. So this was the neck ultrasound. It showed that the neck was scanned using high frequency, 7.5 I think it's heart or something, linear probe, and then both thyroid lobes and isthmus are enlarged, nodular, and heterogeneous with an anechoic left lobe cyst measuring 1.1 by 1.2 centimeters in size noted. The trachea and both carotids are normal, and jugular are normal. An obstetric ultrasound, what was seen was a single live intrauterine pregnancy at 22 weeks and 4 days. Next slide. The breast ultrasound, the left breast appears enlarged with a mixed echo mass noted in the whole breast. The right breast tissue appears normal, so multiple nodular masses were seen in the left breast. So the chest X-ray that was done, what you can see is a huge mediastinal mass shifting the trachea towards the right. Basically that. So this is how the patient looks like. That's the neck mass. And there's those nodular swellings on the body. The left breast is swollen, and also the entire left arm is also swollen. That's her on anterior photography. And that's the back area. So why we decided to present this patient was so that you can formulate if there is any differential diagnosis that can be given, how to prepare the patient for referral to a level 6 hospital, and plan for appropriate referral. If you would accord suggestions on how to alleviate symptoms awaiting histology results and definitive treatment, and when to refer right now or after histology diagnosis, any other investigations needed before referral, and if we would be able to create a multidisciplinary team at referral center in advance. Next.
Thank you.
Thank you. Yeah.
Are we alone?
Hello. Great. Sorry.
Yes.
Okay.
Yeah, we are here.
Yes. Yeah. Sorry, I got lost a bit.
Yes. Are you back? Hello?
Yes, you're back. I think. Yeah, we are back.
Yeah, so we have this patient who is 22 weeks pregnant with a left huge mass on the left side of the chest. We are not sure whether it's mediastinum or whether it's just the chest wall, but from the chest X-ray, if you look at the way it's shifted, it seems like the mass is also in the mediastinum. The patient is dyspneic, is at echo 4, and is pregnant at 2 weeks. So
how many weeks?
22 weeks gestation.
Okay, so it's third trimester.
Yes, we are now moving towards the third trimester too.
No, not yet.
Not yet. We are moving towards there. Just a few more weeks. So
she's para what?
She's para 4. She actually has. She's para 4.
Can we get that histology as soon as possible? Is it possible?
That's the problem. Histology usually takes around a week or 2. So we wanted to discuss that before. What do you guys think? Should we wait for this histology as she's there, or what do you think we should do? And even if we decide to wait for the histology, is it something that we'll be able to sustain, whatever it is? Can we sustain that pregnancy inside there? Or do we need to eliminate it?
I think in this case, the mother is paramount. I don't think she can wait. She can carry that pregnancy to term per se. This is left. I think probably Greg, you can make that call and discuss with the patient. But I think which lab did it go to? I know, like most pathologists, if you call up to them and say that this is an emergency kind of a situation, they will prioritize that case. I don't know which lab you send the pathology to.
Speak.
So we sent the biopsy to a lab path experts, and we were assured it would come out in 5 days.
That's good now.
Yes, I mean, if you can actually call them and tell them that this is kind of an emergency, the patient is dyspneic, short of breath, and all that, then we should be able to do something about it. Then right now it's really difficult. I just suggest that in the meantime you can support the patient with steroids, nebulization with bronchodilators, and possibly just with dexamethasone bronchodilators and some morphine for pain. And then you expedite the pathology. Once we have that, it will be easier. Because yes, it will be easier. And if it is whatever it is, I will actually recommend that you discuss with the mother about TOP, and you commence treatment for the tumor.
Okay.
Even if how long is the history? From
3 months.
3 months. 3 months is true. 3 months. Actually, she's not even sure. She says the mass started on the neck, then went to the chest. The other person, she says it was chest mass to the neck. We don't know which is which.
Okay.
We think this patient will not be able to be managed here. I don't know what you guys think is, because maybe you might at one point need a cardiothoracic. You might need to use it at one point. If it's a surgical case, it's a benign tumor.
Okay. Hello?
Yes. Hello.
I think it's okay. You can actually send the patient across.
Yes, we'll send the patient.
Just let the patient first, probably. Hello?
Yes, we are listening.
Yeah, you stabilize with steroids, analgesia with some morphine, and then we can actually take over the management. But ideally, it will be great if you send the patient with histology, so that we don't the whole process. If you can call the pathologist, inform that this case has been discussed at tumor board and we are in urgent need of at least a preliminary histology. Otherwise, I will say you can do a POP. If he confirms the malignancy, I will say you do a termination of pregnancy and treat as a cancer of a non-primary initially until you get maybe the histology and immunos later on.
When was the biopsy done?
I think a few days ago. We did it on Friday, is it?
Thursday.
Thursday. Okay. So my take would be I'm in agreement with Dr. Opakas with if we can follow up the histology report. There is a way we if the case is deemed to be like really necessary and the patient is in critical or worsening condition like this, the report can be, or reporting can be fast tracked as opposed to really taking all 1 to 2 weeks. So the pathologists on the other side as well would really need that information, because you may not be aware that you're really waiting for this thing to do the next level of management. And then again, I agree, it might be worth following up the result, even if it's today, and then before you do the referrals. Because my experience is once you refer such patients, they tend to like that connection between the histology and the patient being referred usually is lost, and then eventually they start again the whole procedure of getting the biopsy, processing and everything, which takes longer time. And then again, if a diagnosis, a differential in this particular case is something like a lymphoma, so if it's a lymphoma, then it might not even be surgical per se. So really, I could, if you give me the details, I could get in touch with one of the pathologists there.
Fine, we will. That is Keitan, is that?
Itabale. Yeah, this is Keitan.
Okay, fine. That's the Tabale who is doing it, isn't it?
Yes, it should be Dr. Itabale, and I have his contacts. I could link.
That would be great. So thanks. I think the patient will be coming there. You have a bigger team to be able to manage that. There are too many complications around that patient.
Yeah.
That we might not be able to manage here.
True.
Yes, Greg. Please let the patient come with a pathology.
Yes.
Or as the patient comes, we don't have to do everything again all over.
Is there any other thing apart from the
Thank you.
pathology? That's okay.
Images. The images would be great. Yeah.
It was difficult to get the MRI because of the positioning of the patient. They couldn't position the patient. So we can't get MRI. We have to rely basically on the radiographs which are there. Thanks. I think that's all from us today.
Okay. At least even with the chest X-ray, that's good enough. But yeah, thank you.
Okay, from our end, I'd like to thank you all for participating in today's tumor board. Just a reminder, the cases, let's send them early as Thursday so that we can plan, we can invite the necessary consultants so that at least we can have a very robust tumor board. So thank you all, and see you next week on Monday. Thank you.
Thank you.
We're getting better. Cheers. Okay.
Nimeandikia text.